Hello, everybody. I'm Alex Hoffman. Thank you so much for being here at COVIDCon 2020. And I'm excited to share with you this topic. It's a question that I've thought of since the first days of COVID. And it's the idea about the initial infectious dose of COVID virus exposure and whether or not that makes a difference for disease severity. So some of these ideas go back into the history of medicine and the foundations of germ theory. It's a picture of Louis Pasteur in his laboratory. And there's this idea that's persisted from Pasteur and Koch. And it's perhaps not a literal idea from them, but it's an idea that stayed in my mind and probably the minds of many medical students. And it's that if just a single bacteria, a single microbe can escape sterilization, it can go on to multiply, causing disease, causing illness. Of course, that's true. That's right. One bacteria can rapidly multiply and take over a petri dish or a person's body. And this idea is the foundation of germ theory, pasteurization, Koch's postulates. But it raised the question, I mean, could a person get sick from a single virion, a single virus particle of COVID? We'll explore that further throughout the talk. In regards to Dr. Pasteur, here's a picture of his initial experiment showing pasteurization. He had a broth, it was very nutritious for bacteria to grow in. He boiled it in a, it's called a sealed gooseneck flask where air and bacteria wouldn't be able to enter the broth. He then proceeded to have one group that he set aside, he protected from contamination. The other one, he shattered the top, and lo and behold, it was quickly infected with bacteria. Amazingly, that concept of sterility and pasteurization, protecting it from one single microbe, still persists to this day. There are some of his flasks that survive and are in museums. They're still
6-year-old I don't want to confront diagnosis because I don't see pediatric patients.
For every one of you who's ever been in the operating room setting or practiced sterile technique, you know there's this constant thought in your mind, I got to prevent every single bacteria. I need to make sure that not even one bacteria contaminates the sterile field. And so when we're thinking about infectious dose, infectious disease, we often think in terms of a dose response curve. So the common terms are the LD50, the lethal dose. It's a dose at which 50% of the exposed hosts will die. It's also the infectious dose 50. It's the number of microbes required to infect 50% of the experimental host. It's often measured in colony forming units. Exactly what constitutes the infection is up for debate and depends on the particular organism. But generally speaking, the more virulent the infectious disease, the lower the infectious dose. Just an example, the idea of infectious dose is well known in bacterial disease. It's easier for us to count them. One of the most frightening ones is Shigella, where there's an estimated infectious dose of less than 10 single bacteria that are capable of causing systemic illness. So it's something that's well known to medicine, but perhaps more difficult to quantify when discussing viruses. But when we think about this concept of the dose response curve, it's a phenomenon that may be universal to biology. There have been numerous studies over the years. They're not super frequent that these studies are done, but they have pretty compelling evidence that there's a dose response curve for viruses such as influenza, varicella, the original SARS back in the early 2000s, MERS. These are close relatives of COVID-19. Other viruses, bacteria, and even plants and the plant pathogens that infect them have a dose response curve where organisms or hosts that are infected with a small number of particles are more likely to have mild disease, and hosts that are infected with a huge initial infectious dose are more likely to have severe manifestations of that disease. Now, this is a law of averages. There's no particular rule Certainly an organism that was infected with just small infectious dose could easily go on to develop severe disease, especially if they're a patient that's immunocompromised or something like that. But in general, it appears that initial infectious dose plays a role in disease severity. So we're going to explore that in terms of the COVID pandemic. Can you get sick after just one virion? At this point, no one knows, but it raises the question, what is the infectious dose of coronavirus? And what does the dose response curve look like? When I first started reading about the coronavirus and seeing it, I was shocked by how many young, seemingly healthy healthcare providers were sickened and even killed by COVID. And I wondered, in the providers that were on the front line, had they been exposed to a massive dose of coronavirus, perhaps before masks were widely used, perhaps before there were face shields? And I wondered whether or not that large initial infectious dose could have played a role in severe disease that we saw in younger healthcare workers, many of which ended up on the front page of the news, very tragic deaths, young doctors just out of medical school or residency with families that were otherwise healthy, but succumbed in the early stages of the virus. There was a fascinating study looking at the dose response curve in Syrian hamsters. Of course, this is not something that we can test practically in humans. It would be unethical to ever infect a human with coronavirus, of course, but a Syrian golden hamster is a widely accepted model for coronavirus infection. It causes respiratory disease. It creates some mild infection, and it's also an organism that's capable of transmitting the virus by aerosol droplets. So the dose response curve for these hamsters, this experiment only looked at two particular doses, as well as a placebo. The low dose was 10 to the third plaque forming units. That's 1,000 viruses that were administered to a hamster. The high dose was 10 to the 5.6, which is about 400,000. So a big difference between them. Because as you can see here, the black line is the mock or the placebo group where the hamster received no virus. This is looking at the percentage of weight change, which is a good approximation of symptom severity in a hamster or any other small mammal. As you can see, the hamsters that got the low dose had some degree of weight change, but not as much as the high dose, and it was able to rebound a little faster. Whereas the animals that got the much higher dose had a much more extensive weight change and weight loss before eventually rebounding. This same phenomenon was shown in a scoring system of these hamsters' chest CTs. They developed a grading system to look at the respiratory damage in the lungs. And once again, a similar phenomenon. Hamsters that received the placebo had essentially no symptoms or no changes to their chest CT, whereas the low dose was a more mild injury than the high dose. Interestingly, the viral titer measured from the animal's blood was essentially equivalent between the high dose and the low dose infections. That's been something that has been seen in other host infection models, notably in influenza virus. The same viral titer once the infection is actually going on, but the symptoms and the disease severity are often much less when there's a low dose. The pathophysiology of that is still being worked out, but one of the most compelling explanations to me is that it's not so much the virus that damages us and kills us, it's the body's immune response to that virus that can cause some of the severe manifestations that we talked about in the first session. And I think the most compelling explanation so far is that with a low initial viral dose, it may actually provoke a more mild immune response, so that 5, 6, 7 days later, when the body starts to generate more T cells, natural killer cells, there's not the intense immune response to the virus that leads to hypercoagulability, ARDS, and numerous other severe symptoms. So I think that's the most simple explanation I can come up with, and to me, the most compelling one at this point. Just draw your attention to a very cute seeming study about hamsters and wearing masks. Unfortunately, this is not a picture from the actual study. On this slide right here, there's a photograph showing the setup where they placed surgical masks between hamster cages, looked at whether or not coronavirus could be passed between a hamster that was deliberately infected and one that was nearby. The main finding from this was that hamsters were much less likely to contract an infection with a surgical mask. And thinking is that allowed fewer particles, fewer virions to go over. They may have gotten a lower infectious dose. And that was reinforced by the finding that hamsters that did get COVID-19 with masking had much milder manifestations of the infection. Raises the question about whether or not that happens in humans. And the early data that we have back is difficult to go by. It's very difficult to stage a control group, an experimental group in this. But some findings that have intrigued me have been that on one of the cruise ships that adopted early mask wearing, they had asymptomatic rates as high as 90%. In a factory and also a seafood plant in Oregon, where I live, they tested all of the workers during the course of an outbreak, and they found that 95% of the workers were asymptomatic, yet they'd all been wearing masks. And so I wonder whether or not these patients were developing antibodies, but developing very mild or non-existent reactions because they were getting a low initial exposure dose. I think it's a trade-off between symptoms and an antibody response. I wonder, is there a sweet spot between generating antibodies, but staying safe from severe symptoms and being able to pass the disease on to a lot of other people? I think it's still something that's being worked out, but I'm very intrigued about whether or not there's a sort of a mythical sweet spot of a low, but not teeny initial infectious dose that might confer some antibody protection. Where do we go from here? The data shows strongly that you should continue wearing masks. The final thing to think about is whether or not there could be any protection from low dose exposure, especially repeated low dose exposure, that might lead to immunity in someone like a healthcare worker. That I'd like to say thank you and wrap things up. Thank you so much for coming to COVIDCon and for your support of this conference. Look forward to the discussion later. Thank you so much. Next, I would like to introduce Dr. Saurabh, who is joining us all the way from Illinois. And Dr. Saurabh Bansal is an associate professor of clinical medicine, the Department of Internal Medicine at the University of Illinois. He's been on the teaching faculty for the past 10 years, frequently works with medical students and residents, and very involved in the simulation curriculum. And Dr. Bansal has been working on the front lines of the COVID pandemic since it arrived in the United States. We'd like to thank him for that and thank him very kindly for joining us this morning to share his talk with us today. So Dr. Bansal, please join us, and we will pass the microphone to you. Thank you.
I think Dr. Divya wants to say something about Dr. Bansal. If Dr. Divya is around, she wants to say a couple of words about Dr. Bansal, I think. Dr. Divya, are you there with us?
Hello.
Yeah, Dr. Divya. Go ahead.
Hello, first of all, Dr. Vijay Mohan, thank you so much. With this endeavor of yours, you proved that distance doesn't matter if you have a passion for medicine, and distance learning is a way to go. So we are all proud of you. Thank you so much.
Thank you.
Dr. Bansal, I've had a chance to work with Dr. Bansal, and I just want to say that he's another passionate doctor I've met in the recent times in lines of Dr. Vijay Mohan. I've done some research work with him, and I know that he's a wonderful teacher and a very popular teacher as well. So welcome, Dr. Bansal. Glad to meet you today.
Okay, well, thank you everyone for such a great introduction. Thank you, Alex. It was wonderful. Thank you, Dr. Pramod, and many thanks to Dr. Vijay Mohan for organizing this. As you can see, we are sitting very far apart, but technology has brought us a lot closer. So I am from a kind of suburban town in Peoria, Illinois. So it's a little bit far away from Chicago. And it's called Midwestern. It's in the Midwest region of the United States. So I'm going to share my screen here quickly with you and then start my presentation. Okay. Can everybody see my screen here?
Yes.
Okay. Okay, thank you. Okay. So I think some of these things may have been covered by previous presenters from the panel discussions, but and some of these things that I'm going to talk about, you might find you may not have heard about, but these are, I think it's an important topic or important to know from the aspects of knowing how this disease presents. Because the more you know, the better it is. So what I was planning to talk about is atypical or inconsistent